Riyadh because the government had pressure to bring him back. They wanted him back, and so he's gone back. But he was on faculty here so he did his cardiology here, then did his EP fellowship, then did in.
Thank you. Right. Okay, good morning, everyone. Welcome to Wednesday morning cardiology rounds. Today we have Dr. René Boudreau, one of our R6s in cardiology, who's going to be presenting on antiplatelet therapy at my request. So thank you for that. So go ahead, René. We look forward to your presentation.
Perfect. Thanks, Dr. Statnik, for the introduction. And I want to thank everyone who's logged in and who's come to Fuss Center to hear the talk. And then I also want to thank Dr. So, who's been my research supervisor and clinical mentor for several years now and has helped me put this presentation together as well. So the goal of the presentation today is kind of just to update everyone on the most recent literature on antiplatelet therapies and then present some new strategies that people have developed based on this specific kind of field of research, and we'll also go through some of the most up-to-date guidelines. So this figure here highlights all the main antiplatelet trials up to 2021. So these are all basically landmark trials. So no small trials have made it into this. And the main reason that there's been so many antiplatelet studies on antiplatelet therapies is that these outcomes matter to both us and to our patients. When we're talking about antiplatelet outcomes, we're talking about death, MI, stroke, and bleeding. So PCI, which is one of the biggest advancements of modern medicine, really relies on antiplatelet therapies to work. So even knowing, though, that this is an important class of medications and having a personal interest in the field, when I looked at this slide for the first time, my first thought was, how is it that we've not answered all of the antiplatelet questions, right? It feels like it should just be, we've got all the right strategies, let's move on, especially when we've had so many big landmark trials. But this next slide starts to explain on why there's so many antiplatelet studies and why there'll remain to be so many antiplatelet studies. So although not as nice as the last slide, what they've done here is on the top, they've actually divided it up on studies that are focused on ischemic events. So these are studies that are trying to reduce the event of ischemia by either increasing the potency of the P2Y12s or prolonging DAPT. So they're also color-coded and kind of subdivided in there. And then on the bottom, we actually have all of the studies that are focused on reducing bleeding events. One thing that's interesting to note here is that, until 2012, there was no studies at all that were focused on reducing bleeding events. And then into the early 2020s, we can actually see that there's more studies per year that are noteworthy that are focused on reducing bleeding events. And that likely reflects kind of a shift in the PCI culture where PCI technologies and stent strategies have become so much better that ischemic events are now reduced, and now we're focusing more on kind of bleeding events. And then I also wanted to take kind of the chance here to highlight when the most recent guidelines have been published in this field, mostly to show that there is significant research that's come out since most of the recent guidelines. And so this is when the most recent American guidelines were published in 2016. These were the most recent Canadian guidelines in 2018. And then finally over here, these were the most recent 2020 European and STEMI guidelines. So we'll refer back to these guidelines throughout the talk. And then in this slide, we can continue to see why antiplatelet decisions can be so complicated. As clinicians, it's no longer enough to give everyone the same antiplatelet regimen. We really need to be personalizing antiplatelet strategies on specific patient factors. And what we're seeing in the slide on the very top is we're seeing bleeding factors that you should be taking into consideration when you're making these decisions. And on the left, we have clinical variables such as previous bleeding, anemia, CKD, and then in the middle row, procedural characteristics that you should be taking into account. And those are things like non-radial access, the specific type of anticoagulation that was used during the procedure. And on the right, we have scores that are designed to guide us to distinguish which patients are at higher risk of bleeding. And that's the ARC-HBR and PRECISE-DAPT, two of the common ones that I will refer back to during this presentation. And then on the very bottom row, we have clinical variables that are associated with increased ischemic risk. And those are things like acute coronary syndrome at presentation, advanced age, or procedural features such as bifurcation two-stent strategies, multiple lesions treated. And then we have specific scores on the right, which help us determine a specific patient's ischemic risk. And two that I like are the ESC thrombotic definition and the DAPT score, which we do frequently use here at the Heart Institute. And in the middle, I won't talk about this or my presentation as much, but we have patient factors that affect antiplatelet response. Most notably, we have a group of patients who are clopidogrel non-responders. And so just know that we do have assays and genetic testing that can test for these things, and then we can change our antiplatelet strategies based on those specific results. And so if all those factors weren't enough, something else that we need to take into consideration when we're treating patients with antiplatelet agents is that the risk that we're trying to mitigate, which is ischemia and bleeding, are actually there are temporal factors that come into these specific risks, and they're not always equal. We know that when we're treating someone with an ACS with PCI, that there's very high upfront ischemic risks, and that's why we frequently will tolerate intensified therapy, even in patients who have high bleeding risk upfront. But then as these risks change and then become, inverse in some certain circumstance, we do need to reassess our antiplatelet therapies. It's no longer enough to wait till the 12-month mark to reassess, because there's likely some missed opportunities on optimizing our antiplatelet strategies before the 12-month mark. So now we'll talk about the specific drugs. So in Canada, we have 4 antiplatelet therapies that are available to us. On the left, we have aspirin, which is an NSAID. It's a irreversible COX-1 inhibitor. And then on the right, we have our 3 P2I12 agents. And of note, in Canada, all 3 P2I12 are now available and are available in a generic format. So we had lost Prasugrel for a number of years in Canada. About 12 months ago, it has come back to Canada as a generic version. So do keep in mind that Prasugrel is now an option again. And then as far as the P2I12s, we have Clopidogrel and then the 2 more potent P2I12s, Prasugrel and Ticagrelor. One of the main difference with Clopidogrel to the others is that Clopidogrel has a 2-step biotransformation to its active drug, while Prasugrel is just a 1-step biotransformation and Ticagrelor is a direct inhibitor. And the reason that I'm telling you about this biotransformation step is, when we're treating ACS, especially with antiplatelet therapies, we really want our therapies to act quickly. So this was the onset offset trial, and what they showed here was on a time axis, the antiplatelet activity or the antiplatelet inhibition activity of Clopidogrel and Ticagrelor. And what we're seeing is by 2 hours, Ticagrelor is already having a very strong antiplatelet activity, whereas Clopidogrel takes much longer. And in fact, even already at about the 1 hour mark, the Ticagrelor is likely already inhibiting a stronger effect than Clopidogrel does at its maintenance dose. And this is a similar study, but instead was done with Prasugrel compared to Clopidogrel. And again, what we're seeing is the platelet inhibition is much faster with Prasugrel. And on the box on the right, they've actually shown the proportion of patients that have high on-drug platelet reactivity at certain hour marks. And what we're seeing is at 30 minutes already, more than 50% of patients who had received a loading dose of Prasugrel are already reaching what we would define as an adequate amount of antiplatelet inhibition. And then at the 2 hour mark, nearly 98% of patients are basically therapeutic or reaching adequate antiplatelet inhibition, while on the right, Clopidogrel at 2 hours, less than 50% of patients are adequately inhibited. And then even at the 24-hour mark, we're still seeing up to 30% of patients who we would consider to have high on drug platelet reactivity. So now that we've kind of met the factors that we need to take into consideration when we're treating these patients, and we've met the drugs themselves, I wanted to chat about a few different antiplatelet strategies, go through a few of the landmark studies for each of those, and then discuss, the guidelines and how these might be applied in kind of a real world setting. So I'll go through DAPT with high potency P2I12, prolonged DAPT, short DAPT, and then finally maintenance therapy. So onto the potent P2I12 trials. So we'll start with Plato. I think everyone knows Plato, but basically they randomized over 18,000 patients with an ACS to ticagrelor versus clopidogrel. And what they found was that when we used ticagrelor in this patient population, we saw 1.9% absolute risk reduction of MACE for an NNT of 53 to prevent one MACE event. So quite a strong outcome. Notably, it did reduce all-cause mortality, and this came at the cost of a 1.2% absolute risk increase of TIMI major bleeding. And then the next question that comes from that is, are the potent P2Y12 inhibitors the best therapy for all ACS patients? And the popular age trial tried to answer this question. What they did was they randomized 1,000 patients to either clopidogrel or ticagrelor in the setting of an ACS in a patient population that was over the age of 70. So the question is, are MI patients who are over 70, are they different? And what we saw in this trial, and just to go one step back, although popular age was planned to be a potent P2Y12 versus clopidogrel trial, over 95% in the potent group got ticagrelor. So it's more of a ticagrelor versus clopidogrel trial. And what we saw is that there's no difference in ischemic events in patients over 70. So you're no longer getting that ischemic benefit in ticagrelor versus clopidogrel. But what you are seeing on the Kaplan curve on the right is an increase in bleeding. And then they ran a net clinical outcome inferiority and superiority trial. And specifically what they looked at was MACE, moderate and severe bleeding, and combined it. And what they saw that was that clopidogrel was non-inferior to ticagrelor for those specific outcomes. And then they ran a superiority analysis. So they can't actually say that clopidogrel was superior when we combine those outcomes. The p-value was actually 0.11, but certainly numerically lower in the clopidogrel group. So it raises the question that there may be some patients that even in an ACS population may not benefit as much by clopidogrel. So now onto the Prasugrel trials. So this was Triton 38, which was one of the first Prasugrel trials. They were comparing it to clopidogrel. Again, large study. They randomized over 13,000 patients. And what they saw was that in Prasugrel versus ticagrelor in an ACS-only population, that they had a 2.2% absolute risk reduction of MACE. And again, this came at the cost of added increased major bleeding of absolute risk increase of 0.6%. One of the more important findings that came out of Triton is that in the specific subset of patients who had had a history of TIA or stroke, that giving them prasugrel over clopidogrel is actually causing harm. So in this group specifically, what we're seeing is when we combined ischemic events and major bleeding events, so only major bleeding was included in this, is that we're actually increasing the rate of events from 16% in the clopidogrel group to 23% in the prasugrel group. So a 7% absolute risk increase in that patient population. So certainly, patients that we should not be giving prasugrel to. And the other thing we saw was in patients over the age of 75 or under 60, the net clinical benefit of prasugrel now disappears. So there's no longer an advantage at treating those patients with prasugrel at the dose that was given in the Triton trial. The next prasugrel trial that I wanted to chat about is ACOST. And this is an interesting trial. What they basically did is they took 4,000 patients who were biomarker positive and STEMIs and then randomized them to getting prasugrel load at the time of diagnosis or a prasugrel load after the angiogram once we knew the anatomy and it was planned to have PCI at that point in time. And they looked at outcomes at 7 and 30 days, and they specifically looked at MACE on the left and bleeding on the right. And what the ACOST showed us is that pre-treating patients who you would plan for an early invasive strategy did not reduce ischemic events, but did increase bleeding events by quite a significant amount. The pre-treatment group had a 2.9% risk of major bleeding, while the group that got loaded on the table had a 1.5% increase in major bleeding. And there's a couple of things that we really need to know about the ACOST trial, though, is it said early invasive strategy, and they had defined it in their paper up to 24 hours, but the mean time to angiogram in this study was 4.5 hours. So certainly difficult to apply that to our setting because very few of our NSTEMIs are actually getting their angiograms within 4.5 hours of diagnosis. And also 55% of the patients in this group or in this study had femoral access PCI. So in our setting, we're using a lot more radial access than that. But even if you take the access-related bleeds out of this study, it is still a significant increase in TIMI major bleeding. So quite a thought-provoking trial on how we would manage our P2I12s up front. And then finally, the ISAR REACT trial. So this was ticagrelor versus Prasugrel in ACS patients. One of the important things to know about this trial is, they prescribed Prasugrel as per the drug monogram. So specifically what they did with Prasugrel is in patients who had unstable angina or an NSTEMI, they did not receive Prasugrel preloading, while the ticagrelor group did get ticagrelor preloading, while Prasugrel only got it on the table once they knew the anatomy in these NSTEMI patients. They also excluded patients who had a TIA or stroke. And then from the results of the last trial, in older patients over 75 or patients who weighed under 60 kilograms, they actually got a lower dose of the Prasugrel for maintenance dose. And this is what the ISAR REACT trial found. So basically, they randomized over 4,000 patients to TIC versus Prasugrel, and they actually saw that Prasugrel reduced the rate of MACE by 2.4%, or absolute risk reduction of 2.4%. So this was quite an interesting finding and somewhat unexpected by kind of the community that treats these patients, but also the individuals in the trial. And, a lot of people will say that the reason that they found that Prasugrel reduced MACE compared to ticagrelor is if you look in the study, there was actually a higher proportion of patients who discontinued the ticagrelor at 15% in the TIC group versus 12% in the Prasugrel group. And the patients who discontinued ticagrelor also discontinued it earlier than in the Prasugrel group. Although in a real world setting, that might actually strengthen the finding of this trial because, we're talking about ticagrelor, which is a BID drug that is known to cause dyspnea in a large subset of patients, compared to a drug that is a once-a-day drug that may not have the same side effect. So you wonder if in a real-world population, if that's the reason that we saw the outcome, it may even be more pronounced if it was used in the fashion that they did in ISAR REACT 5. So now onto the specific guidelines for the high potency P2I12s. So these are the American guidelines. They basically give a 2A recommendation for both ticagrelor and Prasugrel over Clopidogrel in the setting of ACS. And they also give a class 3 or harm recommendation to Prasugrel in patients with a TIA or stroke. The Canadian guidelines very similarly recommend ticagrelor and Prasugrel over Clopidogrel in this population. But I think this is the more kind of thought-provoking and kind of provocative of the guidelines for antiplatelets. So this is specifically the European guidelines. This is the only study or the only guidelines that came out after ISAR REACT 5. And I want to bring your attention just a few points here. So the first one is that Prasugrel, they had actually recommended Prasugrel over ticagrelor in patients with an NSTEMI. The next guideline I want to bring your attention to is that they actually say that routine pre-treatment of P2I12 in patients with an NSTEMI with a plan for early invasive. So they recommended against it. So they're saying if you think you're going to be doing your angiogram within 24 hours, you actually should not be pre-treating your patients at time of diagnosis and should only be loading them on the table once you know the anatomy. And then finally, they gave a 2B to pre-treating. So they're saying you can pre-treat if you don't think that you're going to be able to do an angiogram within 24 hours and only in patients who don't have a high risk for bleeding. So, obviously, some of the trials can't be taken into our system. ACOST, they got to their angiogram very quickly. Similarly, ISAR REACT 5, they got to their angiograms quite quickly. And those were the trials that they weren't preloading in. But, we're kind of practicing in this 2B as per the European portion where most of our NSTEMIs are not done within 24 hours. So they're saying it's reasonable to load, in patients who are not at high risk bleeding. So, although I'm not suggesting that we should necessarily adopt this, but it kind of gives us pause in saying, in patients that are high risk for bleeding, we may be able to find an alternative, such as loading them with Clopidogrel earlier on, or not loading them and seeing what they have on the table, because we may feel that the bleeding risk outweighs that. So certainly there's some kind of alternative strategies that could come from this specific guideline and the trials that this is based on. And then these are my kind of takeaways from the high potency P2I12s. So first, ticagrelor and prasugrel reduced MACE in patients with ACS when compared to clopidogrel at the cost of increased bleeding. Second, while our system may not allow us to practice exactly as in the ICER React 5 study, the findings of the ESC guidelines offer alternatives to our current practice patterns, and at the very least, we should be using prasugrel in situations where we may want to load a P2I12 on the table, or in patients who are not able to tolerate ticagrelor, such as dyspnea, or patients who prefer a once-a-day drug. And finally, prasugrel is contraindicated in patients with a history of TIA or stroke. And the risk-benefit ratio of high-potency P2I12 is less clear in older patients. And so, on the topic of encouraging increased prasugrel use in kind of our setting, this is something that our group had published. So basically, we had retrospectively reviewed 1,854 consecutive patients that were treated with PCI at the Heart Institute. And what we found was that 209 of these patients, or 11.3%, were actually de-escalated to clopidogrel, and 60% were actually de-escalated while in hospital. And while a good number of these, from what you can see on the figure on top, were de-escalated for bleeding reasons, at which point it would be very appropriate to de-escalate them to clopidogrel, a very high proportion of them were actually discontinued for non-bleeding reasons, and of those, the majority were dyspnea. So, certainly if the clinician had initially intended them to be on ticagrelor, presumably this was for an ACS indication. So these patients, now that we have prasugrel back on the market, it may be very reasonable to actually transition them laterally to prasugrel, especially because we know in that patient population there is an ischemic benefit. So this could be some place that we could take advantage now that prasugrel is back on the market. So now moving on to the prolonged DAPT strategy. So one of the more important trials that have come out in the prolonged DAPT was the DAPT trial. And basically what they did was they randomized a mixed ACS and non-ACS population, nearly 10,000 patients, to stopping dual antiplatelet therapy at the 12-month mark, which was standard in 2014, or continuing for a longer proportion of time. And in this study was DAPT up to 30 months. And one of the important notes in this trial is that you had to be randomized, you had to tolerate the first 12 months of DAPT. So these are patients that had not had ischemic events, had not had bleeding events, so they had tolerated their dual antiplatelet therapy for the first 12 months. And in this specific patient group, what we saw is that a prolonged DAPT does reduce MACE by an absolute risk reduction of 1.6% at the cost of increased bleeding. But one of the interesting findings that came out of this was that there was a numerically increase in all-cause mortality at 2% in the prolonged DAPT group versus 1.5% in the shortened group. And that nearly met significance. The p-value was 0.05. So based on that signal for increased mortality, they then moved on to looking at kind of doing a meta-analysis of, at the time, all of the DAPT trial or prolonged DAPT trials that were published. And here what they found was, although there is still a numerical increase in all-cause mortality that actually just crosses neutrality, so it almost is significant, what they did find was that certainly a prolonged DAPT strategy in these patients was associated with an increase in non-cardiac death. So based on those trials and that meta-analysis, certainly there are patients who benefit from prolonged DAPT, but there are likely others that benefit less or are even potentially harmed. So then the question comes, are there other patients that might benefit more? And Pegasus tried to answer the question of, do MI patients benefit more? Are they different? So what they did in Pegasus TIMI-54 was they randomized patients who had had a MI in the last 1 to 3 years to basically aspirin alone after 12 months versus continuing DAPT with either ticagrelor 60 milligram BID or ticagrelor 90 milligram BID for a period of 3 years. And what they found in Pegasus TIMI-54 was, again, reduction in MACE at the cost of increased bleeding, but now that mortality signal actually went away in PEGASUS-TIMI 54. And this was a meta-analysis that came out after PEGASUS 54 that only looked at patients who had had an MI. So in these more than 30,000 patient meta-analysis, what they found was that in MI patients, we're actually reducing MACE and all components of MACE, yes, at the cost of increased bleeding, but now no longer seeing that signal. And numerically, all-cause mortality is actually preferentially towards the DAPT group, although it did not meet significance. So again, it's clear that some patients benefit from a prolonged DAPT while others benefit less. So then the DAPT score came out, and basically what they did is they used data from the DAPT trial, which is randomized trial, and tried to find out which patients benefit the most exactly. And what they found once they created the score is that a score of 2 or higher is actually associated with a much better risk to benefit profile. So if you had a score of over 2, then prolonged DAPT up to 30 months was associated with a reduction of MACE. So to produce 1 MACE, you had to treat 34 patients, while to cause a major bleeding event, you had to treat 272. So certainly much better. Whereas if your score was under 2, the number needed to prevent a MACE event was 153, while to cause a bleeding event was 64. And that makes intuitive sense when we actually look at the DAPT score components. So basically you get negative points for advanced age, and that makes sense. Those patients are likely at higher risk of bleeding. And then you get positive points for ischemic risks. And the ischemic risks in this specific study were things like cigarette smoking, diabetes, MI at presentation, prior MI, small diameter stent, and vein grafts and heart failure. So when we kind of put that together, basically they're saying young patients with significant risk factors will likely benefit more from prolonged DAPT. So I think this is a nice score that kind of summarizes that. And we do use it at the Heart Institute in our post-PCI clinic. So another area that they looked at to see if patients benefit from prolonged DAPT is patients with complex PCI. So what they did here was that they actually looked at randomized data from a number of patients that stratified their patient outcomes based on the complexity of the PCI interventions. And on the figure, we can see what they specifically defined as complex PCI and kind of the frequency that those patients came up in their populations. And it was pretty standard things like 3 vessels treated, over 3 stents, over 60 millimeters of stent CTOs, bifurcation strategies. And then they broke them down into patients receiving short versus long DAPT. And what they actually saw, so this dotted line are patients with complex PCI who had shortened DAPT. So those patients had more events than patients on the solid blue line with complex PCI who were treated with prolonged DAPT. And it's hard to see here, but the red line, there's actually 2 of them. So those are non-complex PCI patients that were treated with short versus long DAPT. So we're actually seeing that they're not getting an ischemic benefit. So in that patient population that did not have complex PCI, likely are not benefiting from prolonged DAPT and are obviously exposed to the harm of increased bleeding from prolonged antiplatelet therapy. And this was in a mixed ACS and non-ACS population. So finally, the guidelines for the prolonged DAPT. So what we're seeing with, and I'm showing the European guidelines here, although the Canadian and American guidelines show very similar findings. But what they're saying is that in patients that have a high ischemic risk and no high bleeding risk factors, they would give them a 2A to prolonging the DAPT. And then in patients who have a moderate ischemic risk and no high bleeding risk factors would give them a 2B. And the ESC has a specific score that they actually use for ischemic risk that I'll chat about a little bit later. But certainly this would apply to a lot of our patients as far as prolonging the DAPT. And so these are my takeaways for prolonged DAPT. So prolonged DAPT up to 3 years is associated with a decrease in MACE at the cost of increased bleeding. Prolonged DAPT has been associated in an all-comer population with increased non-cardiac mortality. The risk-benefit ratio on patients with an MI and with complex PCI appears more favorable, and the DAPT score and the ischemic risk score can help guide which patients would benefit the most. And then now on to strategies based on reducing bleeding events. So the first one is shortening DAPT. So this was the PRECISE-DAPT study. This was published in Lancet in 2017. And basically what they wanted to do was devise a score that was able to predict patients that are at high bleeding risk that may benefit from a shortened DAPT strategy. So they used a validation cohort, came up with this 5-item risk score that takes into account age, WBC, creatinine clearance, prior bleed, and hemoglobin, sorry. And basically from there, stratified patients into low, moderate, and high risk bleeding. And this is the figure from their specific trial. So a little bit of a busy slide, but what we're seeing here is in the light blue are patients that were treated with short DAPT, and that's their ischemic events. In the dark blue are patients treated with prolonged DAPT, and that's their ischemic events again. And then the red is the same, but now for bleeding events. And then they've stratified the outcomes on the bottom with very low, low, moderate, and high. And high is a PRECISE-DAPT over 25. And what we're seeing is the 3 groups on the left have an ischemic benefit. That's the dark blue bar, being treated with kind of a DAPT that they had said was 12 to 24 months in this versus a short DAPT, which was 3 to 6 months. But the highest risk scores, or the patients with a PRECISE-DAPT over 25, actually no longer had that ischemic benefit. There's actually a numerical increase of ischemic events in patients treated with a prolonged DAPT, but did have a significant increase in major bleeding. So, with the PRECISE-DAPT in mind, this is something that we published this year. And basically what we looked at, when you look at the components or the individual components of the PRECISE-DAPT, you think these are also things that are associated with increase in ischemic events and increased mortality. So what we wanted to do is we wanted to better define the ischemic and mortality risk of these patients in the high PRECISE-DAPT group. So we did a meta-analysis looking at 12 different DAPT trials that had data based that stratified on low under 25 versus high over 25 PRECISE-DAPT. And so what we had found was that in almost 39,000 patients with a low PRECISE-DAPT versus almost 15,000 with a high PRECISE-DAPT, is that these patients actually had a 2.16-fold increase in MI and a 5.83-fold increase in all-cause mortality. So certainly these are patients that are having way more MIs and are dying at a much higher rate. So then we kind of wondered, why is it that in the derivation study, these patients didn't at least benefit from a prolonged DAPT from an ischemic perspective? Of course, they are high risk of bleeding and they're going to bleed more, but why didn't they benefit from prolonged DAPT, at least in the ischemic portion of that? And when you look back at the derivation study, only roughly 50% of them had an ACS. And of their whole derivation study, which included 15,000 patients, only 2,000 of them were in the PRECISE-DAPT over 25 group. So it's very possible that PRECISE-DAPT identifies patients that are very high risk and are going to do poorly from an ischemic and mortality and bleeding, regardless of what you do, and a shortened DAPT might be reasonable. But certainly this at least should give us some pause to think maybe this score should be prospectively analyzed prior to kind of adoption. And then now into kind of the newer, fancier data. So this is one of the more exciting trials that have come out in the last few years in the antiplatelet world. So this is Twilight, published in New England in 2019. And basically what Twilight did is they had roughly 10,000 patients that they randomized to a shortened DAPT strategy, but with P2Y12 monotherapy. So at the 3-month mark, they randomized patients to being treated with ticagrelor alone versus the standard therapy, which was 12 months of ASA and ticagrelor. And this was a patient population mixed ACS and non-ACS, but to be able to be in the trial, you had to have at least one additional clinical factor of elevated bleeding or ischemic risk and one angiographic factor that puts you in a high ischemic risk. So these were patients that were high ischemic and high bleeding risks. And what they found was that when you actually drop the aspirin at 3 months, you're not having an increased rate of ischemia, but you are saving on the bleeding. So they did a non-inferiority analysis for the bleeding. So no increase in bleeding when you drop the ASA at 3 months, but you did gain as far as the bleeding, and the bleeding was a superiority analysis. So there's been a good number of trials that have looked at shortened DAPT. So this is a meta-analysis that have looked at shortened DAPT. These are all many thousand patients randomized to dropping the aspirin either at 1 month or 3 months, and then continuing your P2Y12 monotherapy thereafter. And basically, and this was a mixed group of ACS, non-ACS, although the tyco on the far right here was only ACS patients. And what we actually saw is when we dropped the aspirin at 1 or 3 months, we're not seeing an increase in ischemic events as shown in these 4 plots. There is a numerical reduction in all-cause mortality that was nearly significant. The relative risk ratio went as high as 1.03, so it was almost significant for reducing mortality. But what was more interesting, or I guess more notable, was that we were actually reducing bleeding events. So that certainly speaks to, we may be able to drop the aspirin very early in these patients' course and continue with P2I12 and not be increasing the ischemic events, but reducing bleeding events. And this is what the guidelines specifically say about shortened DAPT. So the Europeans give a 2A to dropping the P2I12 in patients at high risk of bleeding. And they say that we can use a PRECISE-DAPT or the ARC-HBR to identify those patients. And this is in an ACS population. This is their NSTEMI guideline. And then they also give a 2A to dropping the aspirin. And they kind of are a little bit more liberal in when you can drop the aspirin. They basically say, make an assessment based on that specific patient's ischemic and bleeding risk. Because, as we can think of Twilight, that would apply to a lot of patients that we could drop the aspirin. So these are my short DAPT takeaways. So basically, shortening DAPT reduces the risk of bleeding. Shortening DAPT in certain patients or with certain strategies does not increase the ischemic rate. The HBR-ARC and the PRECISE-DAPT are 2 scores that have been identified that can help us guide which patients might benefit the most from a shortened DAPT. And then not the trials I've presented. All of the trials I've presented used 2nd-generation drug-eluting stent, but there's some newer trials coming out, such as the Master DAPT, that they dropped the aspirin at 1 month, that are using 3rd-generation stents that are not available to us in North America. So if you're looking at some of these newer strategies, it's reasonable to look specifically at what they used in the trials, because some of the argument made is that the newer stents may have a lower thrombotic risk, and that's why you can drop one of the agents so early in the course. And then finally, the last section of this is maintenance therapy. So the first maintenance therapy that I want to chat about is the COMPASS trial. So as we know, they randomized patients with coronary disease and additional vascular risk factors, or patients with peripheral arterial disease, to aspirin alone, as was typically standard in these patients, versus low-dose rivaroxaban, or low-dose aspirin and low-dose rivaroxaban together. And what they saw in the COMPASS trial was that there was a 1.3% absolute risk reduction of MACE at the cost of a 1.2% increase in major bleeding. So a strategy that we could use in certain patients. But I think even more exciting and kind of as an alternative to both of those strategies. So this is a meta-analysis that was published less than a month ago, looking at trials that continued P2I12 monotherapy after the specific trials strategies DAPT duration. So in more than 73,000 patients in 19 randomized trials, they looked at aspirin alone versus P2I12 monotherapy once DAPT completion. And what you can see in the forest graph here is there's a reduction in MI when you continue patients on their P2I12. And then they did some fancy statistical analysis, and that's the figure on the right, to basically predict the chance that that specific strategy is superior for the other outcomes. And P2I12 monotherapy was more than 50% likely to be better for all other outcomes, including all-cause death, cardiovascular mortality, bleeding, and the other ischemic outcomes. So these are my maintenance therapy takeaways. So basically, P2I12 monotherapy following guideline or study-directed DAPT duration reduces the risk of MI and may reduce the risk of other ischemic and bleeding outcomes. And the COMPASS strategy decreases ischemic events at the cost of increased bleeding in patients with coronary disease and vascular risk factors. And so these are kind of the key takeaways from my whole presentation. And I know I've thrown many studies at you, many different strategies, and that's kind of the point. Antiplatelet therapy is complicated, and a one-size-fits-all is no longer sufficient. We really need to think about our specific patients, and then we need to individualize patient care. And for every patient, you really should be thinking about what's their type of coronary disease, what type of intervention have they had? And then you should look at their ischemic and bleeding risk modifiers. And finally, there's a number of scores, including the ESC thrombotic risk and DAPT score to predict patients that are a high ischemic risk, and then the HBR and PRECISE-DAPT for bleeding. And then, so with all of that in mind, I wanted to just quickly go through an algorithm that was presented at ESC in 2020 by an Italian group. So their PI was actually, he's the editor-in-chief at Euro Intervention. And I'm not showing this because I think that this is the type of strategy that should be adopted in Canada or at the Heart Institute, but more just so we can kind of think about how we should think about our patients and see one algorithm that, you know, a different group has adopted. So they first recommend that we place our patients in one of these specific boxes. So chronic coronary disease, patients with an ACS, or patients with a chronic coronary disease who have had an MI more than 1 year ago, and then the specific intervention that they've had, whether that's PCI, CABG, or goal-directed medical therapy. And then you review the European recommended risk modifier scores. So on the left, we have the HBR arc bleeding. So on the far left, if you have one of those major criteria, you're already at a high bleeding risk category. Just to the right of that is their minor criteria. If you have two minor criteria, then you are in an increased bleeding risk. And so we say that patient is high bleeding risk. And then further to the right, we have the European high thrombotic risk score. So to be in the highest risk score, you need to have one of the procedural characteristics at the bottom. And those are, you know, more than 3 stents, bifurcation strategy, and so on, and a clinical characteristic. To be at moderate ischemic risk, you just need to have a specific ischemic characteristic. So once you've thought about it, you've identified your specific patient's ischemic and bleeding risk enhancers, and you've placed them in a specific category, then they move on to this algorithm. So this is kind of a nice algorithm. You can, you know, we won't go through all of the different permutations, but to give an example, so this slide specifically is for non-high bleeding risk patients. So these patients did not have high bleeding risk factors. And then if you kind of go down, so for example, we'll use acute coronary syndrome and then go down in the PCI line. So what they've identified as their default approach is aspirin plus ticagrelor for 1 to 3 months. So that's kind of a twilight or master DAPT strategy. And then at the 1 or 3 month mark, you then continue on to P2I12 monotherapy with ticagrelor. And then one to the left of that, which they've identified as an alternative strategy for those specific patients, is aspirin plus Prasugrel based on the ICER React 5 over aspirin plus ticagrelor for those 12 months. And then once you reach the 12 months, if you look at their default strategy, they would recommend ticagrelor over Clopidogrel over aspirin monotherapy for continuation therapy. Or one to the left from that, you could use a Pegasus strategy, which is the aspirin plus ticagrelor, or to the right of that, if they have vascular risk factors, a Compass regimen, which is aspirin plus rivaroxaban. So not saying that this is a strategy that is necessarily could be adopted here, or that is, you know, superior to other strategies that people are using, but, you know, this is based on the newest data, and it's certainly quite thought-provoking and provocative on all the different strategies that we could use for our patients, you know, if we really tried to individualize care. And then finally, this is the high bleeding risk portion of that specific algorithm. So what we're seeing here is for basically all patients in high bleeding risk and for all interventions, they're basically recommending just 1 month of DAPT with either Clopidogrel or ticagrelor, and then moving on to P2I12 monotherapy. And they don't really give a specific recommendation for which monotherapy, and they basically say to continue that indefinitely. So again, it's an interesting algorithm, certainly quite thought-provoking. So I'll stop there. And again, I want to thank you all for your attendance and attention.
Thank you, Renee, for that extensive overview. That's a lot of data to try and process. So that's a lot of work. Congratulations. That was well done. If anybody has any questions, you can put them in the chat, or you can raise your hand and we will unmute your microphone. Dr. Ruel, it looks like you have a question. So we will unmute your microphone and then you can go ahead and ask.
Thanks very much. Thanks, Ellie, and René, beautiful presentation. I really enjoyed it. It's always good to get the full perspective. I would just say there's also a whole slew of indications which are still nebulous at our end of the spectrum, i.e. surgery. And as you know, there's even controversy around the exact dose for aspirin monotherapy maintenance, the duration of DAPT in ACS patients. As you know, Plato-Cabbage and Cure and others show that ACS patients benefit from 1 year of DAPT, but that's only subgroup analyses, right? So you can reject it or you can accept it. And when you start pooling subgroup analyses, there are real caveats to doing that. But most people would kind of agree that it makes sense, and I think the adoption is getting fairly high. And thirdly is really the use of DAPT after Cabbage. And we did some studies at the Heart Institute, including Cascade and Target, and actually we put Target together on an IPDMA and published it in JAMA this summer. And as you said, I'm just saying this for general interest. There seems to be some benefit with regards to vein graft / thrombotic events of 1 year of DAPT. However, at the expense of bleeding, and maybe very much to the points of several of the trials that you presented, it may be that the benefit is doing 1 month of DAPT and then preventing most of the thrombotic events after Cabbage, but yet not getting into long-term phase bleeding events. So we have a grant at CIHR that currently studies that. But again, really fascinating topic, and I know there's been leadership from the Heart Institute in developing this. Dr. So, Dr. LeMay, and others. I have one question for you. Where is the individual patient testing at, especially with regards to Clopidogrel responders and non-responders? I think it was Gravitas, and that was essentially neutral. What's the current strategy on this? Before you're going to give, say, Clopidogrel monotherapy, do you test them that they are responders? Does it make a difference, or you just go ahead and do it? Thank you for a great talk.
Yeah, of course. Thanks, Dr. Ruel, for the comments and the question. So I did briefly look at some of the Clopidogrel assay trials when I was reviewing for this talk. And so there is a number of trials looking at should you be escalating patients who are non-responders or who have inadequate platelet inactivity on Clopidogrel, because these would be patients who have who don't respond to Clopidogrel. And then there's also some studies looking at, can you de-escalate patients who are Clopidogrel responders? And so the landscape is still somewhat unclear. There has been some positive trials, such as I think it was PATH PCI, that did show that if you identified these patients and then stepped them up, you were reducing ischemic events. And then there were some other trials that were not positive, looking at other specific assays, such as genetic testing instead of platelet reactivity testing. So certainly it could be a strategy to both de-escalate or to escalate, although the landscape is still somewhat unclear on the utility. I know that, here at the Heart Institute, I have not seen it used. I've got Dr. So, who's quite involved in that research, so I don't know if you had other comments on that.
Great, thanks, Mark. So 2 things. First of all, in regards to your surgery question, I totally agree that the evidence from a long-term treatment on surgery point of view, the data goes towards vein graft patency, but not towards MACE or mortality, at least on a randomized setting. And within that ACS group, especially when you look at, let's say, the Plato or the Trident Cabbage patients, there is that mortality benefit of the more potent drug over the less potent drug, P2Y12. But keeping in mind, as you said, that was not the actual randomization, right? It was not, patients were not re-randomized after bypass surgery. They were just entered into that study as an ACS and continued with that arm. So certainly, I think in that surgery setting, there is lots of opportunities for future studies. We've actually put in a few pilot grants right now, looking hopefully specifically at those issues and even looking at practice patterns within Ontario. Now, with regards to your second question, which is